But from evidence thus far, and I'm sure they can attest to that, it doesn't look like these subvariants have actually been a major factor in driving this plateau instead of a consistent reduction in new infections. When we look at hospitalizations, that side has remained stable with just over 5,000 admissions as of yesterday, with 85% of those admissions being in the general wards, which is only 4.2% capacity of what we are able to cater for in the general wards. So there's still a lot of capacity. 66.7% of the admissions are in high care and 8.4% are in ICU. Now those numbers in the ICU account for just over 7.5% of our total capacity between public and private in terms of ICU facilities, ICU utilization. So at this stage, we can therefore say with confidence that our health facilities, both in the public and private, are not yet under pressure at this stage in as far as COVID-19 is concerned. So they will be under pressure for other things such as trauma and other ailments, but not COVID-19 at this stage. On the vaccination side, we have crossed just 2 days ago on the evening of Wednesday, we have crossed the 30 million doses administered. This took much longer than we had wished for, but nevertheless, we believe that it is still a significant milestone to reach 30 million doses administered. As of last night, we were at 30 million and just over 100,000 in terms of doses, and then with 18,604,000 individuals with at least one jab, which constitutes just 46.7% of the adult population coverage, while 41.6% are fully vaccinated. For the 12 to 17-year-olds, we just over 1 million of those who have been vaccinated, just over 1,100,000 have received their first doses. And when we add the second doses, the number of doses administered for the 12 to 17 years old is just under 1.3 million at 1,276,000. The over 60 years continue to lead the pack in as far as coverage, with 67.2% of the over 60s already vaccinated, and as far as the over 50s, 50 to 59, 63.1% vaccinated. The 35 to 49 years at 51%. And lastly, the most difficult cohort in terms of our coverage is the 18 to 34, which is the biggest in the population, just over 17 million, for whom we're still struggling to reach 6 million. So we're still at 33% of coverage for the 18 to 34 years of age. The Free State province is still the leading one with coverage of 55.5%, followed by the Western Cape just under 55 at 54.5% coverage, Limpopo 53.4%, and the Eastern Cape at 51.2%. The other remaining 5 provinces are struggling at somewhere between 40 and 48% coverage. But I want to mention the fact that in terms of absolute numbers of doses administered and population covered, Gauteng is the leader with just under 5 million individuals who have been vaccinated, with just over 8.4 million doses administered. Now, the reason why Gauteng is still at somewhere between 43 and 44% is simply that they've got a huge population to cover. In terms of the boosters, we're just over 646,000 boosters administered. 3 weeks ago, we launched the dashboard, which showed us the difference in hospitalization between the vaccinated and unvaccinated. And this dashboard is very helpful in that it's still showing that at least 2/3 of those who are currently admitted in hospitals are those who are unvaccinated, and only around 1/3 are those who are vaccinated. Now, yesterday we visited Kamakaki High School in Gqeberha while on a visit to monitor vaccination and other health services in the Eastern Cape province and also in the metro, in the Nelson Mandela metro. We were very impressed to see a sizable number of learners waiting to be vaccinated and very upbeat about receiving their first doses. They did mention that the school principal did mention that he's been working with his school managers, but also with the health staff from the district to plan this pop-up vaccination site, and with the cooperation of parents who had provided consent forms, signed consent forms before the learners could be vaccinated. And we believe that this is a sign of how we must work with the Department of Basic Education to make sure that we can reach out also to our learners at schools, especially at high schools. Our vaccination sites remain open and ready to offer services, including the mobile and pop-up services as exemplified by this visit we had yesterday at the high school in Gqeberha. And we hope to see many more of such, but we will only do this when we have a specific agreement with the schools so that we can make sure that this has maximum impact. We again appeal to all South Africans to seize the opportunity of protecting themselves and those around them now. Now is the time. While the fourth wave remains stable, as I've mentioned, a plateau, though, of course, it's clear that we're not out of the woods in as far as the infection is concerned. We're still above 10% of infection rates. We know that this virus is far from being eliminated, as we have indicated. Many people are still being infected. Many more are still in hospitals, in ICU, on ventilation. So the virus is still very strongly amongst us. And regrettably, still many more South Africans are succumbing to this virus. The only way to get closer to normal safety is for more people to be vaccinated, and also for those of us who qualify also for the boosters. As we know that with the Johnson & Johnson, you qualify for a booster after 2 months, and for the Pfizer vaccine, after the 2 doses of Pfizer, you qualify after 6 months. So all these services are open and ready, and also on the mobile and pop-up. It is expected that by the end of February, we should be able to reach 5% of positivity, as I've indicated that once the schools now are settled, movement is settled, movement of people, we expect the continuing of the downward trend. But there is also expectation that as we get closer to winter, we'll get closer to the fifth wave. That the fifth wave is likely to break as we get closer to winter. Of course, it may even come closer earlier, depending on whether we experience variants of concern much earlier than we did with the Omicron. So only high coverage of vaccination will reduce also the emergence of more variants, and also will provide protection so that more and more economic and social activities can open. A week ago, Cabinet announced changes to a number of practices that we have used for the containment and prevention of the pandemic. These changes had initially been announced through a circular issued by DG Buthelezi late in December, just before Christmas, but which was later withdrawn, much to the consternation of many South Africans, especially from the medical profession. It caused a lot of confusion. The consultations which we needed to embark on and the alignment with previously gazetted regulations has now been finalized, and we are now in a position to confirm the application of the advisory which we received from the MEC just early in December, which Dr. Jeremy Nell will speak to. So as a result of the conclusion of those consultations and taking this to the Coronavirus Council and to the Cabinet, and also to the Presidential Coordinating Council with the provinces, we can now confirm as follows. One, that we will discontinue quarantining of contact cases for COVID-19. So contact cases will no more be quarantined, so will no more be sourcing quarantine sites, as we have done previously, where we acquired hotels and other facilities for quarantine. So this is going to stop immediately. 2, there will be no need for testing of contacts who are asymptomatic. Instead, if you test positive as a way of, as I'll indicate under certain why people would sometimes test positive and being asymptomatic, they should only take extra precautions in as far as mingling with people very closely for 5 to 7 days while observing whether they're going to develop any symptoms. Thirdly, contact tracing by health workers, including community health workers, will stop immediately. But in situations where there is a cluster outbreak in a clearly identifiable congregate settings, including in workplaces, we encourage telephone-based alerts to be given to those who may be affected by these outbreaks. So if you are in a particular meeting and somebody ends up testing positive, we encourage that the organizers, or if it's in a work situation, that the supervisors in the work should alert people who otherwise need to take precaution because they have been in a cluster outbreak. Fourthly, those who test positive on routine testing, such as travel or in meetings but are asymptomatic, should not isolate, but should observe the emergence of symptoms, taking the precautions which I've mentioned earlier on. The next point is that for mild illness, isolation is reduced from what we had given. We started at 14 days, came to 10 days. We're saying for mild illness now, people can isolate at home for 7 days, and they don't need to test again when the symptoms are gone. You can only go back to work and mingling with people after 7 days, of course, depending on whether the mild symptoms have actually ceased. The next point, moderate to severe cases, which will usually end up in hospital after discharge, they need further 7 days at home for isolation, and after that, there is no need for further testing. But going back to work, if you are a health worker, you need to wear an N95 mask for maximum protection, but also keep away from immunocompromised patients. Now, this is also for moderate to severe cases, as I said, who will likely end up in hospital. Also for mild illness, if you are a health worker, you have to do the same. After the cessation of symptoms, if you go back to work after the 7 days, from day 8, you need to wear an N95 mask and keep away from immunocompromised patients for as long as possible. Now, this new regulations apply to vaccinated and unvaccinated individuals. Now, I hope that this gives more clarity. We will finalize the directions in terms of Disaster Management Act and publish this in the Government Gazette in the next few days. So I believe that this will clarify where we are in this regard. So again, I want to take this time to thank our hardworking health workers on the front line who continue to save lives. And again, I want to call on all of us as South Africans to support them and make sure that we can protect them by taking up the vaccination. Thank you very much, Mr. Mohale, and thank you to the other panelists and to the listeners. Thank you.
Thanks very much, Minister, for the update. And indeed, doesn't mean we must lower our guard because we're still living with this pandemic. Without wasting any time, I'm going to hand over to Dr. Michelle Groom and Dr. Yasat Wasil to give us an epidemiological update. Over to you, Doc.
Good morning to everyone, Honourable Minister, colleagues and the media. Right, so just to give you an update on South Africa's trajectory, so we have just over 3.6 million laboratory confirmed cases, and as the Minister has indicated, we had this very rapid increase with our fourth wave, a slower decrease, and we seem to, over the last 3 weeks, have plateaued in terms of the number of cases. Very similar number of cases that we saw in the past week compared to the previous week, and we have a moving average of around 3,000 in this week. So if we have a look at the sequencing, so very clearly you can see each of our waves has been dominated by a different variant of concern. And you can see with the fourth wave, this has been driven by the Omicron variant, as we all know. And as with Delta, we ended up with time seeing many sublineages, which means these are different variations with slightly different mutations. And so with Omicron, we're also seeing we've seen these three major lineages in terms of Omicron. The BA.1 was the original one that we saw, and that one has a sublineage now, the BA.1.1, and we also have the BA.2. If we have a look over the last month, sorry, I'm just trying to see why my slides are not going. Oh, sorry. In the last month, you can see in December, most of this was the BA1 or BA1.1, and we had a small proportion of the BA.2. And so you can see in January, we have a higher proportion of the BA.2, which is the sublineage. And we are monitoring this. I think we're trying to increase our sequencing from those provinces, especially where we are seeing increases. And at this stage, there's no indication that there would be any additional, that there would be differences between these different sublineages of Omicron. As we saw with Delta, there were lots of lineages and we didn't see a lot of difference between them, but we will keep monitoring and obviously keep monitoring for the emergence of any new variants. So just in terms of the weekly incidents, so as you can see, all provinces were coming down, and we have seen some increases in some of the provinces in the last week, mainly Free State, Gauteng, Limpopo, and Mpumalanga in the Northwest. And if we have a look at the incidents, you can see in the older age groups at the peak of the fourth wave, still our older age groups with the higher incidents, these have all been coming down. And at the moment, we're seeing in the past 3 weeks, this increase in incidence particularly in the 10 to 14, 15 to 19-year-old, and slightly in the 5 to 9-year-olds. And this is really in keeping with the schools that went back 3 weeks ago. And you can really see that this is very much mirrors what happened in the second half of the third wave. Because if you remember the first half of the third wave, we had increased restrictions. There were school holidays, schools were closed. And when schools reopened, we did see this very similar pattern of increases particularly in that school going age. Between 5 and 19. And very similarly now, the initial part of our fourth wave was really during school holidays when schools were closed. You'll remember at the beginning of the fourth wave, we also started seeing those initial cases were in the younger age groups and then spread out into the older age groups. And so we are seeing this increase, but I mean, in terms of comparisons even to levels of the third wave, the incidence is still relatively low. In terms of the number of tests, our number of tests are still very similar week on week for the past few weeks. We have come down to a percent testing positive, just over 10. That also seems to have stabilized, a very small increase from the past week, but we're coming down off a very high percent positivity kind of in mid-December of almost 37. If we look at percent positivity of the provinces, you can see as well that the increases that we're seeing are mostly in the northernmost provinces, with Gauteng, Mpumalanga, and Limpopo, and small increase there in Northwest, although it was not significant, and also in the Free State. And as yet, we're not seeing the same increase in the coastal provinces, bearing in mind that schools did go back slightly later in those provinces, so we may see slight increases in the next week or two. So this is the percent testing positive if we have a look at the different age groups. And so you can see the fourth wave started off very much being predominated by the younger age groups. That peaked earlier. We then had that peak in the older age groups slightly later. And you can clearly see that the plateauing, of our cases is really due to increases in the under 20s. But you can see this has had a steady increase, seems to be plateauing, and slightly less in that 0 to 9 year age group. Just looking at those provinces where we are seeing the increases, and just clearly seeing that this is being driven by the younger age groups, particularly the 10 to 14 and 15 to 19-year-olds. In Mpumalanga, similar picture in Limpopo, Northwest, Gauteng, and Free State. But once again, not yet, reaching even, what we'd seen at the end of the third wave, and also not what we were seeing at the beginning of the fourth wave. So I think just to summarize, our sequencing data for January is still showing dominance of Omicron, with 99% of those being due to Omicron of our sequences. The BA.1 is still dominant. We are seeing this increase with the BA.2, still trying to get more information on this particular sublineage. And there's very low frequency of the other variants that we'd seen in the past. And so we are increasing sequencing from those provinces where we're seeing the increases, monitoring the proportion that is due to BA.2. And so rest assured that we are monitoring for any new variants that may occur as well. So nationally, we've seen a very similar number of cases and percent testing positive this last week, and it really has been the pattern in the last 3 weeks. And I think this is a combination of decreases in the older age group with slight increases in the younger age group. And at the moment, in the past week, these increases have been limited to Free State, Gauteng, Limpopo, Mpumalanga, and Northwest, and very similar pattern with the percent testing positive. And this is driven mainly by the 19 years and under age group, where we've seen this increased incidence and percent testing positive. And I think really this is very much to be expected. I think as we move forward with, going into what will soon be the third year of this pandemic, we know that our younger age groups are still have low vaccine coverage rates. And so we would expect the movement of infection into the younger age groups. We started off our vaccination program in the older age groups. There's a lot of disease, and we know that seroprevalence is also higher in our older age groups. So our older age groups are very much more protected than our younger age groups. Thus, we do see this move into the younger age group, which is expected. And I think with opening of schools and the movements between kids, I think it's not unexpected to see these increases in the school-going age group. We saw a very similar pattern at the end of the third wave. And I think it is expected, similar to what we saw with the fourth wave, to have this increase and a decrease once you use up the susceptibles. So I think, we just need to, the one thing just to monitor that we're not getting spread into the other age groups. But at this stage, I think not unexpected that we'll be seeing kind of small clusters and outbreaks in the school at this stage. I'll stop there and just hand over to Dr. Jasat just to present on the hospitalization data.
Good morning, Honourable Minister, colleagues and the media. I'll take over from Dr. Kroom and just share with you some data on hospitalizations in the fourth wave. So by most metrics, the fourth wave is close to an end, meeting the threshold for the end of the wave. Coupling of cases, admissions, and deaths. And so to show you that, when you look at the cases, admissions, and deaths over the 4 waves, you can appreciate that in the fourth wave, there was a lower proportion of cases who needed to be admitted and a lower proportion who died. And just looking at that a different way, when you compare the fourth wave to the third wave peak, you can see that confirmed COVID-19 deaths, and so we monitor the excess mortality from the South African Medical Research Council. And in the fourth wave, we've seen a very low rise in excess deaths, and it's peaked and returned to the lower bounds of what's expected in terms of mortality. So just to look at some admission and death trends from the DATCOV surveillance system, on the left, you can see the trend in hospital admissions from 666 hospitals in the public and private sector. You can see that in the fourth wave, there were more admissions in the public sector, but in both the public and private sector, there's a decreased trend in admissions and returning to a low baseline that we saw pre-wave. On the right, you can see in terms of deaths, there was a much lower peak of deaths in the public and private sector in the fourth wave, and both have shown a downward trend for many weeks. Just showing you the admissions by province, you can see that what was different in the fourth wave is that it was a very tight, shorter wave. And each province peaked at lower levels of hospitalizations than the second and third wave, but quite similar levels of hospitalization as the first wave. And what we saw was almost a simultaneous increase, peak, and decrease across all provinces, whereas in the previous waves, there was a much slower evolution of the wave between provinces. This is the deaths, in-hospital deaths by province, and you can see that deaths peaked at a much lower level in all provinces compared to all the previous 3 waves. So just a lot has been said about the admissions in the pediatric population in the 4th wave. I wanted to show you this is the number of admissions by age group, and whereas in the first 3 waves you can see admissions were highest in the 50 to 59, 60 to 69, and then 40 to 49 age group. But in the 4th wave, you can see admissions were highest in 30 to 39, 20 to 29, and then it's a bit hidden, but you can really see that 0 to 9 years in blue was much higher in terms of the numbers of admission than we saw in previous waves. And just to break down the pediatric population a little bit more, in the 3rd wave, we saw that second peak of admissions amongst school-going children, 15 to 18 years that Dr. Kroom was talking about. In this 4th wave, we saw much higher levels of admissions in 15 to 18-year-old teenagers, and in young children, 1 to 11 months and 1 to 4 years. So pretty much 1 to 5 years, and the teenagers 15 to 18 years showed the highest levels of admission in the 4th wave. So just to share a bit of the data on where we stand with admissions and deaths in the provinces, when we compare the daily average of the current 2 weeks and the previous 2 weeks, you can see that in all provinces, there's a decrease in hospitalization and a decrease in death. However, so sometimes aggregate trends hide the picture that are happening at lower levels. And so when you look at districts, you can see that there are a few districts that are showing an increase, some very small numbers, not really anything to worry about, but just to watch, but some with bigger numbers. In Free State, Harib showed a very small increase, but a bigger increase in city of Tshwane with 294 new admissions in the past week and a percentage average increase of 4%. So that's one to watch. Also in Limpopo, increases in Capricorn, Sekhukhune, and Waterberg. In Mpumalanga, increases in hospitalization in Geertsbande, and in Northwest, increases in Gakamudiri Mulema. So the provincial picture in terms of hospitalization in most provinces shows a decreasing trend, but I just want to focus on the provinces that have some increases in hospitalization. So first is Gauteng. We can see a decrease since the early peak in the public and private sector that's just leveling off a little bit. But what you can see on the right-hand side is admissions by district. There is a slight increase in city of Tshwane Metro. And when you look at Gauteng by age group, you can see that there are increases in admissions in the 30 to 39, 20 to 29, and then in children as well, in particularly the 0 to 9 years. And here you can see it better in the pediatric picture. You can see a slight uptick in children of all ages. Next is Limpopo. You can see in terms of hospitalization, there's an increase in the public and the private sector in the past week. And you can see that increase is in a few districts, Capricorn, Sekhukhune, and Waterberg. And when you look at the age group of admissions, you can see that it's in the young children, 0 to 9 and 10 to 19, but also some increases in young adults, 20 to 29 and 30 to 39 as well. And here you can appreciate the increase amongst young children. And finally, in Mpumalanga, the trend still looks downward, but just looks like a bit of a leveling off. And on the right, you can see by district that there's a little increase in Geertsbande. And when we look at it by age again, you can see the increase in 20 to 29 age group, and then the 0 to 9 age group, or under 5s as well. Also, as we've previously reported, we now, at the end of the wave, are better able to analyze severity and death in the 4th wave compared to the previous wave. And when we look at a multivariable analysis of the factors associated with severe disease, when you compare to wave 4, you can see there was more severe disease in wave 1, 2 times higher, wave 2 and wave 3 almost 4 times higher. And so you can clearly see that in wave 4, we saw a much lower risk of severe disease. Similarly, when we looked at the factors associated with death, comparing the wave periods, you can see that compared to wave 4, there was a 2 to 3 fold higher increase in deaths in the first, second, and third wave. And just looking at that by different age groups, on the left is severe disease. And you can see for every age group, and particularly for adults, there's much lower severity in the fourth wave compared to the previous two waves. And in terms of deaths, those who died in hospital is much lower in the fourth wave compared to the previous two waves. And just to remind you, we've been collecting data on vaccination status, not complete, but we have for about 30% of patients vaccination status. And on the left, most admissions are in unvaccinated people. And on the right, most deaths that have been reported in the fourth wave have been in unvaccinated people. So just in summary, we have reported less severe disease and death, and similar is being reported from many other countries. And the question is it because of lower intrinsic virulence of Omicron or because of immunity that's built up from prior infection or vaccination? There are some studies already that suggest that there is lower intrinsic virulence of Omicron. And I think the studies around immunity are showing that the vaccine effectiveness is high against hospitalization, more than against symptomatic disease. And so because of the high seroprevalence in South Africa, it's likely that T-cell immunity does protect us against severe disease somewhat. Even though many people got breakthrough infection, not many people had severe disease and needed to be hospitalized. We did see more admissions in children in the fourth wave, although it was less severe disease, and they're reporting similar in other countries. And it really seemed like it was the very youngest children, children under 5, particularly children under 1 with the highest admission rate. The reasons why is, the Omicron favors the upper airways, and children with small upper airways may just be more symptomatic. But also, I think it's just related to the admission criteria in children. Children are admitted with pediatric protocols for fever, hydration if they have gastrointestinal symptoms, and for seizures, but many of them did not require oxygen and ventilation. Also, we know that children have lower seroprevalence from a recent study done in Gauteng in November, and also children have lower vaccination coverage because vaccine program only extended to them in October, and the coverage is still quite low. But also we saw more incidental admissions, children admitted for other reasons. Also remember that influenza A had a late seasonal peak also around November, December. And we also probably are under-testing in children and under-diagnosing cases, so that it seems like the children admitted to hospital seem to be a high proportion, but those are likely the children that are tested, the ones that are admitted to hospital. Just finally, the fourth wave, we are close to the end of the wave threshold, but we've seen a slower down wave compared to the up wave. And just now in the last week, we're seeing increases in admissions in Gauteng, Limpopo, Mpumalanga. It's mainly children, probably because they've gone back to school, and then the spillover to the parents who are at home in the 20 to 40-year age group. So we've seen some admissions in those age groups. But certainly we continue to see the decoupling of cases, admissions, and deaths in the fourth wave. And the hospital capacity was not breached at all, despite no increases in national restrictions in the fourth wave. We saw no strain on bed capacity, oxygen, and critical care beds. And I think just to make the point finally of the importance of vaccination, a lot has been said about how mild Omicron is and how we had a less severe fourth wave compared to the previous waves. But that doesn't mean that everyone's protected. There still are people who get severe disease and die. There still are pockets of people who are either unvaccinated or have not had prior infection. And about 5,000 or 6,000 people did die in the fourth wave. And so I think people shouldn't be comforted with the fact that we had a very mild fourth wave nationally and across provinces. I think there's still a very important rationale to vaccinate, because certainly the people who did end up in hospital and who died were largely those who were unvaccinated. I'll stop there. Thank you so much.
Thanks very much, Dr. Yassad and Dr. Michelle Group, for that update as far as epidemiological report is concerned. So as the minister has indicated that today we are joined by a member of the Ministerial Advisory Committee on COVID-19, Dr. Jeremy Nel, who's going to also emphasize on the issue of regulation as far as isolation, quarantine, and contact tracing is concerned. So I'm going to take this opportunity to hand over to Dr. Jeremy Nel to take the podium. Over to you, Doc.
Thanks very much, and welcome to everyone, and welcome to the Honourable Minister and all the members of the media. So here I just wanted to go through some of the rationales to the changes of quarantine and isolation, just so that it's clear to as many people as possible through this. I think that it's quite clear that we are in a different phase of the epidemic, and that's been covered by Dr. Jasad just before me as well. Really suggesting that we do have now a lot of immunity in the population, largely from natural infection, some due to vaccination too. And in either case, it does seem to prevent at least the majority of severe disease. So that's an important thing, and that's probably the main reason why we've seen an uncoupling of the cases from severities. We've seen a lot of cases in the fourth wave, but not the same degree of severity. There's also, it's as each variant has become more and more transmissible, it's become harder and harder to achieve any degree of significant containment as we've got due to the measures we currently have. And so it's moving towards a more focus on mitigation is probably more viable and sustainable anyway. And then, of course, there's a lot that we've learned about the virus in the last 2 years. We know, for example, something that wasn't known when the outbreak started in 2020 is that there's a high degree of asymptomatic disease. In other words, many people can be positive, but actually not have symptoms or have only trivial symptoms. And that percentage, rather, it can be extremely high. In fact, in one South African study, it was in excess of 70%. But in any case, it's a large amount, and that makes it very difficult to contain as well. And it also has implications for what it means in terms of testing. And the key thing here, and I'm going to cover it in the next slide really, is that such a small proportion of cases are diagnosed. And that's really one of the key drivers that is the rationale for changing what we now recommend in terms of quarantining and isolation. So, as I said, the big thing about it is that we really, in terms of quarantining, we quarantining contacts of cases, but it turns out we don't find a lot of the cases, and that's not at all unique to South Africa. That's the case in almost all the countries, apart from very few countries which test almost absolutely everybody. But for the vast majority of countries, we're actually only finding a minority of cases, and that's a very small minority of cases. In South Africa, it's probably less than 1 in 10. Perhaps even 1 in 15 cases are over-identified. And that's for a number of reasons. One is that, of course, if you don't have symptoms, you won't test, and for the vast majority of cases. Even if you do have symptoms, you may not test because you might find it's expensive or inconvenient, or you just don't want to test for whatever reason. And then even if you do go and test and you do have symptoms, the tests themselves are maybe only about 70% sensitive. In other words, they're going to miss some cases of positive disease just because the tests aren't perfect. And so when you put it together, like I said, we probably only find about 1 in 10 to 1 in 15 of cases. And if that's the case, then it clearly means we're not finding the right people to quarantine either, because you're not finding the majority of cases, which means you're not finding the majority of contacts. We used to also isolate for high-risk contacts, quarantine rather for high-risk contacts. And I should remind again the audience, quarantining is not if you are positive, but if you're exposed to someone who's positive. That's what quarantining refers to. And so for high-risk contacts, that was usually defined as being within 1 meter to 2 meters for more than 15 minutes without appropriate masking, for example. We now know that probably also doesn't reflect the most modern understanding of how the virus is spread, which is slightly more by so-called aerosols, in other words, through the air, with very microscopic droplets that we didn't know it played as much a role previously. And the new variants are also more transmissible, and of course the effect of the transmission in terms of immunity is different. So what it means to be a high-risk contact as well is probably not applicable anymore, unlike the previous regulations said. Big thing about quarantining is the enormous cost to society. With that, it takes a lot of people off the workforce who are well, and that applies to healthcare facilities and constrain them. And of course, one of the key ideas behind control measures and containment measures and mitigation measures is to prevent the healthcare system from being under strain. And this, by taking a lot of healthy healthcare workers out of the workforce through quarantining, actually can increase the strain. It's not, of course, just healthcare workers. It's across every discipline of the country, from other so-called essential services to government functions to just everyday businesses. There's enormous cost to this, and takes people, for example, out of schooling as well. There's a large downside to this. And in general, we found that at least the adherence to this anyway is pretty erratic. People are not good about quarantining at the best of times. And so that was the rationale, I think, for the suggestion to the Department of Health that that we drop quarantining. And I think that time, will show that this is the right move. I think every country will eventually end up at this point, just at varying degrees of speed. But I do think this is a very, very good move in terms of where we are in the country and what we need to be doing. I don't think quarantining has any discernible public health benefit, given that we find so few people to start with who are positive. Quarantining those very few contacts of those very few cases is not going to be shifting a curve in any stage. And that's the predominant reason, although there are others, for why quarantining, I think, should be dropped and has been. Similar sort of rationale to isolation. Again, we're only finding 1 in 10 to 1 in every 15 cases, which really means that, again, from a public health perspective, isolation is pretty limited in what it can achieve. Isolation, again, remember, is if you are positive. So this is really saying that these at least there is some rationale to persist with isolation, because you're dealing with someone who's infectious at least. But we do know as well that you're much more likely to be infectious in the first few days around symptoms. So maybe a day or two before symptoms start to a day or two after is the kind of peak time for infectiousness. And it does decline pretty rapidly after that. And so what you're left with really is that you get the most bang for your buck in terms of isolation somewhere close to when symptoms start. And then the longer it is after symptoms begin, the less use you have. So it's about finding a balance between the right time to isolate to prevent most of the infections, while not trying to prevent absolutely every possible infection, which would require isolation probably of months, because people can shed virus for that long potentially. So it's really about trying to limit the amount of time that we isolate, but still getting the most benefit we can. Again, there's lots of downsides to society, the same ones we mentioned with quarantining. This is a model that was put together by one of the Ministerial Advisory Committee members, but it's really conceptual to show really at the top here in the dotted line is an individual, showing the likelihood of them transmitting the virus really peaks around 5 days. And Ministerial Advisory Committee suggested 7 in the end, which is what the Department of Health's gone for. The CDC suggested a bit even more aggressive at 5. But you can see after 7 days, there's not a lot of transmission that goes on. But that's for the individual. Of course, what you need to really look at is the bottom line, which is the solid lines, which is what about society as a whole? Because remember, we're only finding such a small percentage of cases in the first place. And really what that suggests is that, again, the public health utility is pretty short after between 5 and 7 days here. So again, that's the rationale for shortening the isolation period, really saying that you're getting the most bang for your buck and probably the best balance in society between keeping people out of the workforce and essential services and other walks of life, and actually still, though, protecting some from onward transmission. And of course, after this period, as the Minister said, we still would suggest very good mask wearing and other measures to reduce the infection risk even further. So that is, again, really the basis of it. Like Dr. Jasset said, we are in a different phase of the epidemic. You can see the enormous number of cases in the bottom right there, but then the excess deaths really not reflecting the same caseload burden that we'd had previously. And so really for that recommendation, this was what the Ministerial Advisory Committee suggested, but ultimately it's very comports with what the Minister said earlier, that really we're trying to limit it from 10 days to 7 days for the vast majority of people. Asymptomatic people are a little bit different, because we know with PCR tests it can last days to weeks past your infectious period. In other words, you might be PCR positive for if you're infectious today, your PCR test may still be positive 2 to 3 weeks later. And that's one of the big reasons why we've never suggested repeating testing to determine if you're uninfectious or not. You can have a positive test and not be infectious if it's past the certain infectious period. And for that reason, when you're asymptomatic, we just don't know where you are in that infectious period. Are you right at the beginning, or are you 2 to 3 weeks past when you're infectious, for example? And for that reason, on balance, it's probably sensible for the vast majority of asymptomatic people not to require isolation at all. Many of them will not be infectious, even though they test positive, because of how long those PCR tests can remain positive. And I'm going to leave it there. Thank you very much, Minister.
Thanks very much, Dr. Nel, for that contribution as far as the regulations or the health protocols are concerned. Without wasting any time, we are doing well in terms of time, and we've got so far, we've got about 8 questions that I'm going to take all of them at the same time, so that we'll have enough time to respond to the questions, Honorable Minister and members of the panel, if you can allow me to go through this first set of questions. Question number 1 reads as follows. I would like to ask the Honorable Minister to address the issue of pregnant health workers who are released at 28 weeks of gestation. Is this still applicable? Question number 2, has the Department of Health formally issued the revised self-quarantine, self-isolation protocols following the cabinet decision on Monday? We will prefer to implement something formal that has been issued by the department rather relying on the media statement. I think the Minister has touched on this, but can still come back and emphasize on this question. Question number 3, good morning, Honorable Minister and the team. As the Omicron surge declines internationally, some countries have indicated that citizens will no longer be required to wear masks in public. Is this a consideration in South Africa? Question number 4, Rian Broadwell from Business Tech is saying the Minister has previously said that the government was set to make a decision on mandatory vaccinations before the end of January. What is the latest in this regard? Question number 5, can Minister and members of the panel please speak to us about mRNA COVID-19 vaccine that is being made in Cape Town? I need 2 voices on this story. I don't know what does it mean, but the members of the panel can respond on this. Question number 6, the Department of Employment and Labor Directive of 11 June 2021 still refers to workers having to self-quarantine for 10 days if they have had high-risk contact in the workplace. Will a new directive be issued? If not, can we assume that the Department of Health circular will be issued shortly, will trump the directive? It's a bit confusing when the departments, different departments are saying different things. Question number 7, can the experts please tell us of those currently hospitalized? How many are vaccinated? How many are not? Additionally, do we know exactly how effective the vaccine is in stopping the infections? How likely are you going to get vaccine? How likely are you to get vaccine COVID-19 if you are fully vaccinated compared to those who are not vaccinated? The last question, US regulators now describe J&J as a 2-dose vaccine, and the WHO also recommends a 2-dose regimen for J&J. The manufacturing company also acknowledges that data better support a second shot 2 months after the first dose instead of 6 months later. With this in mind, will South Africa's official policy change to recommend a 2-shot regimen for J&J? And if so, what will it mean for people who are considered fully vaccinated at dose and those who have received a second dose as a booster shot? This is the first and the only set of questions. I know there was some attempt to respond to some of these questions on the chat, but for the benefit of those who are not connected to the chat, we'll appreciate if you can respond to all these questions. Over to you, Minister and members of the panel.
Sorry for the delay. Thank you very much, Foster. I will take question number 3, which is about masks. And then I'll also take number 4 about vaccine mandates. And then I'll request that Dr. Crisp gets ready to take, or he can, I don't know whether Dr. Bamford may be better placed. I don't know, I'm not very familiar with the health workers released at 28 weeks of gestation. Is it for maternity leave? I don't know. Somebody who may understand it better maybe can deal with that. The issuing of revised directions, DG, if you can get ready to deal with number 2 on revised directions. And then I'm hoping that Dr. Crisp can respond to the mRNA produced in Cape Town. And I think colleagues from the NICD can deal with 7 about vaccinations and hospital. They've dealt with it, but there's a follow-up question. The issue of the 2-dose J&J, I'll weigh into it, but I'm sure that in the team, we don't have anybody from VMAC. Maybe Dr. Chris can also come into it, but I'll make a comment on that. So let me start with question number 3, which is the Omicron surge is declining. Some countries have indicated that citizens no longer are required to wear masks in public. At this stage, we have not been advised to go this route. Again, I want to emphasize that as the department, we are the lead department which advises the National Coronavirus Council and also Cabinet. And we are also advised by the Ministerial Advisory Committee on the COVID, on which Dr. Jeremy Nell is a member of. At this stage, we have not been advised to venture into dropping the masks. I must also just add that a number of countries, there's different approaches in different countries, but the viewers and listeners and participants will be aware that there are a number of countries where the use of masks is still very considered quite essential in the control of COVID. In fact, just interestingly, I was just reading an email from Prof. Abdul Karim on his visit to Vietnam, which Vietnam has got a very tight control on the spread of COVID, doing very well, and they have 100% compliance with the use of masks in indoor and outdoor, and as a result, they are doing very well. So we're going to have to learn from experiences elsewhere. Different countries approach this differently, but we have not reached that stage. So we are not here. We are not there. If we will be there in a month, 2 months, I don't know, but we are not there at this stage. On the issue on the question number 4 by Ryan Brathwell we had expected that our DGs under the body called the National Joint Committee, the NET Joints, will have finalized the proposal on the mandates. It looks like, and maybe DG can also comment on this, it looks like that work was not concluded in time. But when the president convenes the next Coronavirus Council, we will be expecting that team to finalize and report so that decisions can be taken. I think because of other activities, that committee has not concluded, but I'm quite certain that when we have the next normal Coronavirus Council, they will be expected to give us a report and recommendations upon which decisions will be made. I'll invite Dr. Buthelezi to also weigh in on that in terms of what is expected. The question on the J&J with various authorities having decided that it must be a 2-dose. We again, in terms of this, we will be advised by the Ministerial Advisory Committee on Vaccination. At this stage, I think we are covered by the fact that both the VMAC and also SAPRA has approved the 2nd dose, even though I think the question relates to the fact that we consider the 2nd dose as a booster, not as part of the primary vaccination. But in terms of actual coverage, we believe that that is sufficient. We have not been advised differently, both from the manufacturer and also from the VMAC and also from SAPRA. At this stage, we believe that we encourage people to come forward for 2nd dose for better coverage. But we're not at this stage considering, therefore, that this is primary and therefore 3rd dose of J&J at this stage That's not what we've been advised for. So that's basically our basic approach at this stage. Without further waste of time, Foster, let me invite Dr. Crisp to weigh in on question number 1, and Dr. Buthelezi on question 2, and then the others. Yes, proceed, please.
Thank you very much, Minister. So the question that was asked about the 28 weeks of gestation, we're not quite sure. We've been consulting one another in the background what the question is about, and none of us is absolutely certain whether this is a Department of Employment of Labour question or whether this is a question from Department of Public Service and Administration's policy. So maybe if the person who asked the question can give us some clarification, we can answer that question. Minister, you also asked me to speak about the mRNA vaccine being made in Cape Town. So this has been announced previously, and a lot of excitement about the setting up of the facility in Cape Town with the backing of the World Health Organization and teams from Department of Science and Innovation and various universities. And we're very pleased to note that they've been picking up speed very fast with their capabilities, and they have now succeeded in manufacturing small amounts of a vaccine that is an mRNA vaccine similar to the Moderna, or built on the same basis of what we know in the public space about Moderna vaccine. We will be learning more about this in the coming days, and in the next week, some of us from the department will be joining some international visitors to go and look at that facility and hear much more firsthand. But it's very exciting. It's very important for the country. It's one of a number of facilities that we are busy working on as a country, between the Department of Health and Science and Innovation and other partners. So very encouraging. As far as the question related to the different, I think Wendy asked the question, who's about natural immunity and whether people should be vaccinated. Yes, people who think they have natural immunity should still be vaccinated. We do know that all immunity wanes over time. We don't know how much of a sustained immunity any individual might have at any time, but we do know that the stimulation after a natural immunity by a vaccine gives very good vaccination protection, a lot of immunity, and it seems that it does stimulate the T-cell immunity a lot better. So we definitely encourage people who have had an infection, who have not been vaccinated, to go and get vaccinated. There was another question to me about those in the ward who are vaccinated or not vaccinated. As the minister said 3 weeks ago, we did put out this new page on the public dashboard. So I was just quickly looking at yesterday's figures. In the ward, not in wards across the country, not vaccinated, 2,856, partly vaccinated 145, and fully vaccinated 895. In high care, we had 199 not vaccinated, 15 partially vaccinated, and 93 fully vaccinated. And in intensive care units, 237 people who are not vaccinated, 20 who are partly vaccinated, and 135 who are fully vaccinated. I don't have the breakdown here in front of me of how many of those are admitted for COVID specifically, and what other diseases and illnesses they may have. But that's what I can add. Thanks very much. Back to you, Foster.
Nicholas, can you also deal with, just add on the 2-dose J&J?
Sure, yes. So thanks, Minister. Yeah, we've been discussing this I sit in on the Vaccine Ministerial Advisory Committee meetings. So I hear the discussion that's going on. We don't have a formal change in any regimen yet. These, before a formal decision is made, it has to go through the regulator, as the minister has said. So right now, the official definition for Johnson & Johnson is still as a single dose, but it is correct that there's seems to be plenty evidence that a second dose as a primary schedule is advisable, and we may well move to that in the future as the official regimen, and that would be after 60 days. but we still boost, and there are also now many countries who are doing heterologous boosting, and we are likely to move to that as well in the coming months. We need to get our systems ready, but a week or so ago, it became possible for us to use Pfizer as a booster on top of Ad26 vaccine, so in our case, Johnson & Johnson, and we now need to program that into our system. And at the beginning of January, when Johnson & Johnson changed their registrations with or submitted a dossier and approvals were given, an approval was given for Johnson & Johnson to be used as a booster dose after Pfizer vaccination. So these regimens are changing as more and more studies provide us with information about the different immune responses, and we will publish them formally once we have them fully capable within the system and the vaccines are distributed. Thanks very much.
DG, on the formal publishing of the directives after the cabinet decision.
Yes. Thank you very much, Honorable Minister, Deputy Minister, and colleagues and members of the media. Yes, the directives are ready, and we will ensure that they get signed today by the minister. But the regulations are out. So, linking to the other question on the directive from the Department of Labor, I've actually spoken to the DG there to ensure that they revise their directives. However, we must know that the directives are not superior to the regulations. So regulations are superior because they're based on the Act of Parliament. So what has been approved by Cabinet and gazetted by COCTA is what now applies, and it repeals any other issues. Of course, then there are then subservient documents like the directives and the circulars that we're going to release, just to stress on the point. So that is where we are. We hope that we should be able to gazette our directives by latest by tomorrow, once the minister has signed them, but they've been finalized and have gone through the office of the State Law Advisor. Thank you very much, Minister.
Okay, back to you, Mr. Mohale. Foster, we are back to you.
Thanks, Honorable Minister and fellow colleagues. We've got the last two questions from Reuters and Times Live. Alex from Reuters is posing this question to Dr. Michelle Groom at NICD that she said so far there's no indication that there are major differences between the original Omicron lineage and BA2. So does that mean that so far the evidence is that BA2 results in the same clinical symptoms and severity of disease? Is there any evidence yet whether BA2 is more transmissible? Is there anything else we can say at this early stage about BA2 based on what's been seen in South Africa? Last question from Matlas Mpatlele from Times Live. What is the government has announced adjusted level 1 this week, but the Department of Sports has not said anything with regards to increasing spectator numbers. Was this issue discussed during the recent NCCC meeting, and what is the latest regarding the spectator numbers? Not sure if Minister will be able to touch on this, even though it's more on sports. These are the last two questions, Minister and members of the panel.
No, thanks, Mr. Mohale. Let me take before Michelle, let me take the sports one quickly, just to say that indeed these matters were discussed. They are still being finalized. There were proposals by net joints in terms of how to move, but there are a number of complexities with the team must finalize. At the next NCCC, which the President will convene, these matters will be finalized. There are proposals on the table in terms of opening up of sports and arts and culture with the necessary safety measures. So those proposals are being fine-tuned. They will come back, and the final decisions will be made in the next few weeks. I'm sure as soon as the President is convened the next NCCC, those matters will be finalized and announcements will be made accordingly. Thank you very much.
Michelle
can take over. Yeah.
Thanks. So just to give additional details on the BA.2. So I think it is still early days. There was a small study from Denmark, which did show some increasing transmissibility of the BA2 compared to the BA1. And also in that study did find that this was also unvaccinated cases were more likely to transmit. So there likely will be more data in the coming weeks. I think in terms of South Africa, I think we are doing those additional analyses. So similar to at the beginning of the fourth wave, where we were able to, if you remember, the BA.1 has the S gene dropout in terms of one of those TAC PCR assays. And so we were able to compare that to Delta using kind of that as a proxy. And so with the BA2, it has this mutation, it no longer has that estrine dropout. So we're able to kind of use that as a proxy again to be able to compare BA.1 and BA.2. So I think those analyses are ongoing, and we will have more information in the coming weeks. In terms of symptoms, I think we haven't really ever seen marked differences in terms of symptoms with the different variants. And so I think we wouldn't expect there to be differences there. And in terms of severity, once again, I think we will be looking at that in terms of hospitalization, whether there is indication that there's any differences in severity. So I think at this stage, I think we'd need more data. Thank you. Over.
Thanks very much, Dr. Michelle and Honorable Minister. This last one follow-up question, maybe let me take this question before we hand over to Honorable Deputy Minister. Is from Alex News 24, is asking if will the MAC and the government be looking at the issue of mask mandate. This is the last question that I'm taking before we hand over to Honorable Deputy Minister.
Just quickly, Mr. Mohale, to say that I think I've dealt with that. Again, it will be discussed as other countries do effect some changes on masks. Our MAC, our Ministerial Advisory Committee, will make, will discuss the matter and give us advices, but we'll also consider, based on what they advise, we'll also look at the experiences elsewhere. But upfront, I would want to urge South Africans not to really be in a hurry that we shouldn't drop our guard. The virus is still within us. There is ample evidence also that masks do protect the spread, as Dr. Nell mentioned earlier on, that current evidence does indicate that aerosol spreading through the air is actually a strong, a way in which the COVID-19 virus is spreading. So, and I've also indicated that it's not a general approach that a majority of countries in the world are dropping the use of masks. There are still many countries which very strong. I've indicated the experience of Vietnam, where there's 100% compliance, both indoors and outdoors. And there are many other countries. If you go to China, many viewers, listeners, and participants will be aware that, in fact, even by the time that COVID descended on China, it was almost normal culture in China for people in the public, when they walk in public, to be using the masks. So we will examine this very carefully. I know it is an irritant to wear a mask, but I would say that I think we must be patient, because this pandemic is still in our midst. So let us really be patient and continue to use our masks. Thank you very much.
Thanks, Minister, for clarifying that questions. Now we are heading towards closure. I'm going to hand over to Honorable Deputy Minister to do the closure. But just before I do that, Minister, do you have any last parting shot, last word, last message?
Well, look, the message, overall message, is very, very clear and straightforward. And and that message is really, again, calling on all of us to come forward and be vaccinated. We're working very hard on making sure that our message can also reach the younger people. The team is working very hard, and in due course, some announcements will be made as to how we also improve our communication to be able to be attractive also to the 18 to 34 years. That is the age group in which we are still very much struggling with the uptake. But overall, for all South Africans, if you qualify for a booster, please come forward. And that's the way we can protect each other. Thank you very much. And over to Deputy Minister.
Thanks, Honorable Minister. Without wasting any time, I'm handing over to Deputy Minister Dr. Songsen Ntomo to wrap up the briefing. Over to you, Doc. DM.
Thank you very much, Mr. Foster, and good morning to the Minister, the fellow panelists, and the DG and the team that supports the Minister all the time here. Firstly, just to mention that Dr. Jeremy Nel, thanks, Minister, for inviting one of the members of the Ministerial Advisory Committee, because look, there's been some issues that needed their own contributions here publicly. We have issued a statement as a department and working on that. But for him to come and emphasize this as the team member who comes in to advise the minister is very sort of commendable, Mr. Dr. Nel, the issue of quarantining and tracing. The second issue, Minister, I think we are picking up is that we'd like to thank Dr. Jassat and Dr. Michelle Groom for coming in to support the opening remarks of the minister, emphasizing that, in fact, we are seeing an increase on those inland provinces, Gauteng, Free State, Limpopo, Mpumalanga, Northwest. And this picture that is really coming up is that maybe in those provinces, there was a bit of a movement much earlier than the other coastal provinces. And the children and parents moving back to school, back to work, possibly may be an added factor here. We are also comforted, however, to say from the figures of Dr. Jassat, it looks like our senior citizens, 50 to 59 and 60 years and above, were relatively protected from these recent infections, probably because of the high numbers of the people vaccinated in this age group. And also because probably they were not one of those who were in the high movement during this time. So it's really something that needs probably to help us to be alert as they are advising us that maybe we are going to see this coming into the coastal provinces after these inland provinces. But Minister, I think maybe it's another alert that we need to have in our mind that probably we might experience the similar pattern when our universities and TVBS colleges do open up, and that is where there's a majority of the 18 to 34-year-old. We really want to plead. We're not really as government forcing them to vaccinate, but we're encouraging and pleading with them to consider this based from this evidence coming forward here, that in fact there is a value in vaccinations. We decrease massive hospitalizations, we decrease ICU admissions and deaths. So maybe they could really assist us with that. The last one, Minister, is just to emphasize, to add on what you really raised in your opening remarks, to commend MEC Math of the Eastern Cape on the visit that we did yesterday, that had teamwork and with the school, KwaMaxake High School, led by Mr. Ngelwane, the school governing body, all the other social partners who were there, who actually started this very innovative program, not without any disruption to the school, having a vaccination site in the school, getting the learners to come in there in small numbers, 10, 5, and get them to be going back to the class. But I think what was very important, Minister, is the conversation that you had with the learners who were there waiting to be vaccinated. It was very important, and I wish that those learners could actually share some of those videos, alerting and making other learners and other young people to say, I want to come and vaccinate. I think the benefits of my vaccination is far more than the fears that I hear on the social media, some of them which are unfounded. So those were very encouraging comments coming in from the learners of Kwamakage High School. Maybe we should probably find this innovative program of the Eastern Cape being rolled out in other parts of our country without really disrupting schools. And I'm sure Minister would find space and time to really share this with the Minister of Basic Education and maybe roll out, because we now see that this COVID-19 and the other probably new variants will be much more affecting the younger age group, probably because they're not yet vaccinated, because they're the ones who are much more in movement. Let me then hold it at that and say thank you very much. And I hope it has really helped us to be enlightened as the members of the society, and thanks to our healthcare workers who continue to do this fight, and thanks to our Ministerial Advisory Committee assisting us and the Minister and the government. Thank you, Foster.
Thanks, Honorable DM. Thanks, Minister, members of the panel, members of the media for being with us from 8 o'clock until now. We are doing well in terms of time. We're supposed to end this media briefing exactly at 9:30. So we did well. Now it's exactly 9:20. Without wasting any time, I'm going to officially close this meeting, and also like to confirm and emphasize to the members of the media that we're always available, our experts, the Minister, the Deputy Minister, the DG, to take any interviews related to COVID-19, but also with the health service related interviews. I declare this media briefing urgent. Thank you.
Thank you very much.
Thank you.